All right, welcome everyone to the first ever AMA Google Hangout. It's still on delivering care to a diverse patient population. I am Bill McDade. I'm Deputy Provost at the University of Chicago. My focus is on minority issues as well as research here. I'm an anesthesiologist and study sickle cell disease here. I'd like to welcome our guests, our panelists tonight, our Tanya Fancher, who I'll invite to introduce herself in just a second, Dr. Walter Bland, and Ms. Jalila Tucker. So Dr. Fancher, can you introduce yourself to our audience?
Sure. Good evening from California. I'm Tanya Fancher. I'm a general internist out here, and my work with the medical students is on creating tailored clinical tracks for students.
Thank you, Dr. Fancher. Dr. Bland, will you introduce yourself?
My name is Walter Bland. I'm the Associate Dean for Student Affairs and Admissions at Howard University College of Medicine, and I'm also the Associate Professor in the Department of Psychiatry and Behavioral Sciences.
Dr. Bland, thank you very much. And finally, Ms. Jalila Tucker.
Hi, my name is Jalila Tucker. I'm a second-year medical student at Chicago Medical School here in North Chicago, Illinois. I'm originally from California, but I'm enjoying my time in medical school so far.
Well, that's great to hear. So what we're actually doing is going to talk a little bit about how medical education can be used to help to eliminate health disparities. The AMA has a number of initiatives that have really been focused on trying to eliminate health disparities. Participation as part of the founders of the Commission to End Health Disparities not being least among them. We also have introduced a new program at the American Medical Association, in which we funded scholarships or program grants of $1 million each to 11 institutions as part of our Accelerating the Change in Medical Education initiative. That initiative is actually in part how Dr. Fancher's work is being done at the University of California, Davis. We also have the Minority Affairs section of the American Medical Association, which is an opportunity to bring in a diverse viewpoint to the House of Delegates, the policymaking body of the American Medical Association. And we have another initiative that started many years ago when I was chair of the Minority Affairs Consortium called Doctors Back to School, in which we're trying to bring physicians into grade schools and high schools to encourage the start of that pipeline that leads to more diversity in the healthcare system. Well, as part of what I think we can start with for the panelists is maybe an explanation of what your institution is doing effectively to attract and retain a diverse medical student or resident or faculty group. I'll start with you, Dr. Bland.
Here at Howard, we have a Health Careers Opportunity Program grant. That grant permits us to have relationships with 6 elementary schools, 2 junior high schools, and 2 high schools in the Washington, D.C. area, where we have activities for students at those schools as well as faculty to help to increase the pipeline of underrepresented minorities coming into the medical profession. Also, through our HCOP grant, we have a program known as Preliminary Academic Reinforcement Program. This is a program for applicants to our medical schools that allow us to give them a conditional admission if they are successful in a 6-week pre-matriculation program. It permits us to fulfill our mission by bringing in students who are from economic, environmentally, or educationally disadvantaged backgrounds. Once the students are, in addition to those recruitment activities, we have we participate in the AAMC student recruitment fairs, the Student National Medical Association recruitment fairs, as well as the Minority Association of Pre-Medical Students recruitment fairs as well. And the College of Medicine is one of 12 sites for the summer medical dental education program sponsored by the Robert Wood Johnson Foundation. We take in a total of 80 students each year, 60 interested in medicine, 20 interested in dentistry. So that helps us to be able to attract and admit students who are able to fulfill our mission. Once students are there at the College of Medicine, we have academic support programs as well as programs for psychosocial concerns students may have. We have a part-time psychiatrist that has been hired by the College of Medicine only to see medical students, as well as a person who has a background in pastoral counseling as well, just to address medical students' needs. We also have a medical students wellness program to support students once they are in the College of Medicine, to allow them to continue, hopefully, with uninterrupted progression towards their MD degree.
Well, thank you, Dr. Bland. That sounds quite comprehensive. Dr. Fancher, what are you doing at UC Davis in this regard?
So at Davis, I guess we have some similar programs to what you just heard about, where we really start from children all the way up through college, through both at the four-year level as well as the state schools. And then once the students come here, we do offer different programs specifically out of interest to the students. So as you know, California is a huge place, but we don't have an equal distribution of physicians in California, both geographically as well as specialty-wise. So our project with the AMA is a 3-year program through medical school where students who know that they want to work in primary care complete medical school in 3 years and go directly on to a 3-year residency program in primary care. And we found that the students who are interested in this are really those who come from the communities that desperately need primary care, and that for them, one of the barriers to medical school has been the cost of medical school and that and the length of medical school. So many of them come to us having had a second career, or they have families, so they're very attracted to the idea of completing all of their training in 6 years rather than 7, and then entering the workforce 1 year earlier. So that, I think, has been an early successful program for us.
Well, Dr. Fancher, I have to say that one of the things that attracted me to your school is your interaction with the AMSA ARC program and the way in which you embrace students who are the junior college system moving into the college system and on to medical school. Can you discuss that a little bit?
Sure. You know, California, like I said, has lots and lots and lots of students, and the as we all know, the challenges to going through a 4-year college are very complex, and that we have a very robust school system in California. So our school has been very proactive about reaching out to the community college systems and really embracing that experience as formative and really adding to why we want those students to come to Davis.
Thank you very much. At the University of Chicago, we do a number of things at both the student and the resident and the faculty level. But one of the things that we do in common with Dr. Bland is we attend the Student National Medical Association Annual Education Conference. And from that, we were able to bring faculty from a number of different departments and even a program director or two as well. We found that very effective in trying to recruit a diverse residency class. And in fact, in our emergency medicine residency program, half of the first-year class is underrepresented minority. So we're very excited by the idea that we can find a number of high-quality students at that Student National Medical Association annual meeting. Well, we'll move on to another question. And actually, Dr. Bland, you started talking about this a bit. The first question that we have from the outside is from Robert Beltran. And he asked us to share any challenges that you're having with burnout at your medical school at that level, or other issues around stress, anxiety on the way to becoming a doctor. And so, Dr. Bland, you started that conversation, so maybe I'll let you pick up on it, and then I'll switch over to Julia, who might be able to tell us what they do at Rosalind Franklin.
Well, to address the issue of burnout and stress at the College of Medicine, as I stated earlier, we found it necessary to hire a part-time psychiatrist that does not supervise or evaluate students so that they can seek care. It's important that students not have barriers, perceived or real, to prevent them from seeking care. We had found that some of our students were reluctant to use the student counseling service at our university for fear that they would be in some, that the psychiatrist who was a member of the faculty there would be biased in some way against them if they sought care there. So we hired a psychiatrist to provide those services. We also found that some students felt more comfortable talking with a minister, so we brought in a part-time pastoral counselor to work with the students as well. To further provide wellness programs for our students, we have a fitness room in the College of Medicine that students have access to 24 hours a day, 7 days a week. And other student wellness activities include therapeutic massages just before examinations. Some of the students have arranged for salsa classes, activities that tend to be engaging and relaxing for the students. So we realize that stress management is important.
That sounds very comprehensive. I actually just heard a talk about 2 weeks ago at the ACGME building, and it was Lottie Derby, who's from Mayo, who actually has a medical student well-being index, and she does it for physician well-being index too, to measure burnout so that people can help to identify themselves as potentially being burned out. Julia, what happens at Rosalind Franklin in this regard?
So we actually have a variety of programs, both put on by the faculty and staff as well as student-run organizations. So the class council, they actually came up with the idea, Donuts for Doctors. So it's usually before an exam where people take maybe 30 minutes or an hour and just literally just have donuts and coffee and kind of take a break from studying. A recent program that started from the Office of Student Affairs is the Stress-Free Fridays. And so a variety of activities are going to be going on for the rest of the school year just for people to kind of de-stress and have a little bit more fun, a little bit of time away from studying as well. Another program we have is a local organization. They bring in dogs, and people just come and literally play with dogs for about 45 minutes as a way of de-stressing. And lastly, another thing that we have is they started a mindfulness meditation program where students can sign up for, I believe it's 8 weeks, and attend a weekly session just focusing on mindfulness. So there's a variety of programs that we have here that are catered towards students as well as faculty and staff to be able to de-stress and avoid burnout.
Well, that sounds terrific. I love the idea with the dogs. We'll go into another question. What are some of the innovative ways to expose medical students and residents to a variety of cultures and patient communities? We'll go to Dr. Fancher.
Can I ask a question of Dr. Bland first?
Please.
Gosh, I love all the things that you do there, and the massages. I think you could take some lessons from Julia and do donuts for doctors and massages. That would be perfect.
I agree that would be. The therapeutic massages actually are sponsored by our chapel service. So it a value added to having the pastoral counselor.
Yeah, I love that. I love that too. This is fun for me because I'm taking lots of notes about other things that we can do here. So thank you for educating me too.
It gives me meaning to laying on of hands.
That's right.
That's right. You'll have to give me some your contact information after the call. You know, one thing that Davis has done for decades now, actually, is we offer free clinics throughout Sacramento community. So right now we have 8 different free clinics. They are tailored to the local community where they're situated, and it tends to be that those local communities are also ethnically specific. So the first student-run clinic that we had here started about 30 years ago and was targeted for the Asian American community here in Sacramento. Sacramento is made up of about 22% Asian American. And since then, as our student population has diversified and the interests have diversified, we've developed 7 more clinics since then. And now about 80% of our students participate in the student-run clinics on some level. So it's been incredibly interesting. I have to say the students are absolutely committed. They really make the clinics run, and they work with undergraduates from UC Davis as well as from Sac State now, actually, to ensure that those run and to ensure that they are responsive to community needs as well as community preferences. So I think that's been a big piece for us here at Davis.
Well, those are terrific ideas. Jalila, any idea of what sort of things that we might do to improve the cultural and understanding of residents and medical students and expose them to communities?
Similar to Davis, we also have a student-run clinic. Ours actually just started last year. We celebrated the 1-year anniversary actually a couple weeks ago. And I'm not sure if you are familiar with the area of North Chicago, but there's a very dense population of Mexican Americans. So we kind of really reach out to the immediate surrounding community around our university to try to invite them to come in. And I think within the last year, we actually have seen close to or a little over 200 patients, which is pretty exciting for us, especially being a new clinic. Another thing that we do is we actually have a variety of clerkship sites. So I know that, especially coming from our dean, that the way in which he thinks our training should kind of be diversified is by having a diverse amount of or types of clerkship sites that we can go into in our 3rd year. So we have private practice clinics, we have hospitals in rural areas, suburban areas, as well as urban areas, to kind of give each student a variety in terms of experience and working with diverse populations. And then another way in which, in my opinion, that we kind of train to be a little bit more diverse is actually by the student body. So I know recently our dean redefined what he considered to be a value-added group, and not just looking at only racial and ethnic or gender diversity, but also just the diversity of our experiences. And he really kind of looks for people who have these unique experiences to be able to kind of build a community from the ground up. So within the school to then go out into these different clerkships already having experienced people with diverse backgrounds.
Oh, that sounds excellent. Actually, we had a tweet chat this week on diversity efforts, and during that tweet chat with the AMA, I mentioned the idea of a community scavenger hunt. And this is something that came out of East Tennessee State University, led by Dr. Goodrow and colleagues there. And the object was to try to take people who are in their transitional year going into their internship and put them into various community settings on a scavenger hunt, to look for assets in the community around health, and to look where there may be food deserts, and look where there may be physicians who may be there, or where there may be pockets of interest. And I think this sort of thing is important to do to allow people who are just new to a community to understand what sort of health care assets exist in that community, and it helps to put them in touch with what's going on in terms of health needs for the community. Another thing that we do at the University of Chicago is we're very strong on participatory research with both the university faculty as well as the community. So community-based participatory research forms the basis of a lot of our diabetes research that we do on campus and in other areas as well. And when we have medical students who work with us, they're able to go in these communities and interact with people and really ask the folks in the community what their healthcare needs are and what their unmet needs are. And so I think by teaching people how to work with communities, it's really an important way to understand more about what happens in that neighborhood. Well, let's go on to another question.
Oh, can I make a comment?
Yes.
You know, I think to sort of marry what you and Jalea have said in trying to understand your community, and Jalea really speaks to the beauty of the community of medical students that we each have the pleasure to work with, right? And that the risk that really medical students bring to our community. And it seems important to me that we start to embrace that richness amongst the students and their experiences too.
I think that's one of the great values of diversity, is that it helps us to learn from one another and to help us understand the communities in which we're in so much better.
Mm-hmm. We had tried this a few years back, having our students actually go on ride-alongs with the police, with the local police department, to acknowledge that many of our students are not from the local community, but many of our patients live here, and they live and experience things that we have the opportunity to not do, right? That it's a choice for us, and it's not a choice for everyone. And I have to say that those experiences were incredible for our learners, and for one to go to a place where they wouldn't otherwise go, but also to work with the police force and to see what their life is like, because we see them in the emergency room quite often, right? And so now to understand what their role is really in health and mental health care in our community, I think has been quite powerful for us.
Also at Howard, we have our students to rotate at suburban hospitals, seeing populations they generally do not see at Howard University Hospital, and we place our students in preceptorships in office-based practices throughout the metropolitan Washington area, where they have an opportunity to work with more diverse populations than they see at Howard.
Very good, very good. We'll move on to the next question, which is, what are some things to consider when teaching medical students and residents about culturally responsive healthcare? What are the elements of the curriculum that would do that, or what sort of things do you want to make sure that we don't miss in terms of teaching culturally responsive healthcare? Dr. Bland, we'll start back with you again.
Okay. I think it's important that we keep in consideration that culturally responsive healthcare takes into account ethnicity as well as race. A person may identify as Black or Hispanic, but culturally their experiences will differ depending on their ethnicity. For example, I worked with persons from Central America, and I find that it's important to recognize and take that into consideration when I'm working with them as compared to persons who come from Mexico. They have a different experience. In addition, we have a number of students as well as patients and residents from the continent of Africa, especially from West Africa, and our interactions with those from Ghana is different than those from Nigeria or Sierra Leone. So I think we have to make sure that we do not lump everyone into the same group, not taking into account their ethnic differences. Also, it's important that we ask questions about health practices and beliefs that might be important to specific populations that we're working with, and not just assume that we know it.
Well, that's quite excellent, a series of suggestions. I'd like to take this moment before I move on to my next question response, or to respond to my last question, to remind people who are part of the Google Hangout that if you want to send me any questions that you'd like to ask, then feel free to do so, and I'll put those to our panelists. So please do so. So let's go again back to our group here. Jalila, what sorts of things should we make sure that medical students and residents learn about culturally responsive healthcare when trying to fashion a curriculum?
So some of the things that at my institution that people have kind of focused on really deal with providing opportunities that are both inside the classroom, traditional style learning, as well as outside of the classroom. We do have a course where there's a service learning component where we're challenged to go out into the community of our choice, a project of our choice, and kind of engage with the community on topics of health and kind of meeting people where they are and being able to, for example, increase exercise. So building a program that is culturally appropriate. But they also look at culture in different ways. So not only just, as I said before, race or ethnicity, but also kind of age, region of the country, medical practices, health literacy. So really taking more of a holistic approach, I guess, in terms of the information that's being presented and informing us or teaching us that there's so many other aspects, there's so many levels to what influence someone's health, as not just their race or ethnicity, but also these other aspects. And then, like I said before, also providing us opportunities, traditional opportunities in the classroom to learn, but then also outside as well.
Very good. Dr. Fancher, anything in your curriculum that's important?
I think the only other piece I would add to that is that it's probably important that these sort of curricula last for 4 years, or for 3 years, I guess in our case, that they're not sort of one-off or something that you do only at orientation or only in this one rotation. So at Davis we do have that piece where these sorts of experiences that Jalea talked about and that Dr. Bland talked about happen throughout the curriculum for 4 years. And I think that's an important commitment that the school really makes to this type of work.
Very good. I'd be interested to know what sort of innovative things that you think that hadn't been done prior to the time that you implemented them at your institutions. Dr. Bland, I know that Howard has a history of being able to do this, but what do you think has really been groundbreaking in terms of teaching cultural responsive healthcare?
In terms of at Howard, we're now using our standardized patients and ways to teach cultural sensitivity in the delivery of healthcare. We have developed case vignettes where students are faced with culturally diverse patients presenting with certain certain challenges that they have to learn how to work through, and that is something that we were not doing before through our standardized patients activities. Also, we are bringing in patients to talk with students in our classrooms to let them know some of the things that they feel helps to make for a good doctor-patient relationship.
Thank you. Dr. Fancher, I'll go to you. What's your ACE project about, and how is it innovative in that regard?
So our ACE project, like I mentioned, is for primary care, and it's 3 years through medical school connected to 3 years of residency. And when I think about innovations related to our topic, what I had mentioned, the student-run clinics, and there's lots of challenges with that experience, and Jalea, I'm sure, could speak to that too, based on her experience there. Because really, there's one thing to provide free care, but really what you want to do is provide free or low-cost, really, really good care. And so what we're doing with our students, our 3-year students, they're embedded at Kaiser Permanente, which is a large healthcare organization here that provides care in a very thoughtful, population-based way. And what we're learning is that the students are seeing this and seeing this coordinated care and this way to really look at populations, and then coming to the student-run clinics and asking us, can we do that here too? Can we provide the same level of attention? And so we're thinking of these students really as change leaders for our communities to take some of the lessons that they're learning, bring them back to the areas where they really want to work and improve care.
Julia, you mentioned that your school is in a place where there are a lot of people who don't speak English as a primary language. And we know from data by Lisa Cooper and Neil Poe that one of the most important things to do is to have a person speak in the primary language of patients. Is there anything innovative in that regard that, that you're doing at Rosalind Franklin?
I'm not necessarily sure that it's innovative, but we are engaging more students and training more students who are willing and interested in learning a second language, specifically in Spanish, in medical Spanish. So it is something where we've actually, and that's also a student-run course that students are able to engage and learn medical Spanish to then be able to better serve the patients that we do see at the student-run clinic. Also, in our second year, we have preceptorships where students are able to go to predominantly Spanish-speaking clinics and work there as well. So there are opportunities for students to be able to learn specifically medical Spanish in order to be able to engage with patients a lot better.
Okay, I have a question. I'm wondering how you handle the use of interpreters, both professional interpreters and when family members are serving as interpreters for a relative.
Excellent question. Who wants that one?
So at my institution, we really try not to use family members as interpreters. We actually have, it was a student-developed interpreter program that I'm actually part of as well. And we are able to, so as a part of it, we have to do an interview in Spanish. We're provided information to translate both from English to Spanish and then from Spanish to English. And there are a number of small group sessions that we have to attend, participating in a variety of patient encounters, essentially. So history and physical exam, explaining things to patients, and that in order to qualify to be able to do that within the an actual patient encounter. And it also helps that we have quite a few attendings who also speak Spanish as well. So that's kind of where we are, what we're doing at my institution right now. But like I said, we really do try not to use family members unless we really, really have to, which is actually not very often at all.
And could I respond to that as well? And you know, we're at a place where there's lots and lots of different languages spoken, from Vietnamese and Hmong and Urdu and lots of the smaller smaller Asian communities. Where interpreters are far from abundant or sort of not easy to find. So in the hospital system, it's not too hard. We have a great interpreter service, but that's really where the undergraduates have come in and played a huge role for us at the student-run clinics, where that's really one of the assets that they bring is this diversity of language. And so they go through a brief medical interpreter course and then work at the student-run clinics to provide that live translation. But it makes me think about, Dr. Blaine, when you talked about the SP experience and really adding the cross-cultural communication piece to the SPs, we you know, the Hmong community is pretty large here in Sacramento, and we really want to prepare our students to work with this community, but there aren't SPs who are Hmong, right, or who really know much about the experience of being Hmong. So we worked with community members to bring in community members to become the actors, and then to have other community members become the interpreters in those sessions with our students. And it certainly brought great rewards, but it brought great challenges as well, and made us stop to think about the way we teach in those sort of courses, that the actors are accustomed to timeouts and to language that we use, or to the perhaps sometimes the casual nature of the discussions, but that community members are not. So it really led us to sort of step back and say, how can we work with communities but change ourselves too, and change how we train in order to do that better?
Well, an excellent provocative question there, Dr. Bland. You have an answer for what Howard does as well?
Well, as I said, we bring in the persons from the community. to work with us. But for those persons that come from groups where we don't have interpreter service available, we do have to use family members at times. Sometimes during the course of the interview, it's obvious that the person is, I would say, for lack of a better word, filtering the information from the patient. So we have to say to them, tell us exactly what they said, and we'll get a different response. So it's a challenging situation, but one that we feel is important to address in order to provide appropriate care for patients. So we're working on it.
We talk about language. Are there any other situations at your individual institutions that are like language, that you actually have found that teaching people how to interact and interact with and communicate with is also important? I just actually recall a patient I saw last week who was deaf, and so in using a bit of sign language and a bit of gesturing, we were able to get through the situation. But it would have been a lot better, I think, if we had a more feasible way of communicating. Does anybody work along those axes, or any other ones that you think is particularly innovative?
So it seems like the key to that is really teaching students an approach to difference, right? And really to think about any interaction. You don't know what you're going to share or where you'll differ. So really teaching the students to have a humble or cultural humility is a piece that we really emphasize here, that every interaction is a chance to learn, as well as you should, always treating people with respect and humility, regardless of the difference. And I had a fascinating discussion today with a sociologist who's going to come teach with us, and she was talking to me about gender and how gender is not bimodal. That gender is much more complex than that, and that's something I think that I've failed to think about, really, where my soapbox has been looking at the diversity, really the ethnic diversity within Asian communities, and trying to get us away from lumping all, like, the Asian experience into the Asian experience, and to instead think along the lines of Dr. Bland and say, the experiences are really different. Let's just take a moment to ask that question and to understand a little bit better. But she made me take that moment today, right, in thinking about gender. And that gender, just the way that I have been thinking about gender, is incomplete. So to me, these are lessons that happen, obviously, all the time, and it's more of the approach to difference. How do we teach students to embrace difference and respect difference?
I think that's essential. I'm so glad you raised that point. When you think about what organizations or institutions can do in order to deliver high-quality health care to an ever-increasingly diverse patient population, what sorts of things come to mind? What can we do? I'll start with our most youthful person in the panel, Jalila. What can institutions and organizations do to deliver high-quality health care for an increasingly diverse population?
I think, at least at my school, a lot of emphasis and effort's been put into lunch and learns. So it's kind of giving people the option to kind of have an exposure to different topics around diversity. There was one about affinity groups. We've had some on diversity in care. We've had others on just interacting within a professional sense. So it's really kind of on a real, I guess, friendly level in a sense, and kind of really kind of hooking people in just with topics that they might not have even necessarily thought about, but making it kind of a more casual session that they can come in and kind of talk in small groups with other people with similar interests, and kind of figuring out where to go from there is something that I've noticed that they've really done here.
Dr. Fancher, other things that organizations or institutions can do?
I think I alluded a bit to this earlier. I think it's looking at our own practice. So, Davis, we now have an EMR that we've had for several years, but now it's routine for us to ask about language, race, ethnicity, sexual identity. And then, so now that we have that information and that we've said, you know what, this is part of what we do every day, we can now go back and look at whether the care is equitable, at least across those lines through the medical record. So I think that that's really important, and that as our learners come through, that they see that we value, right? Asking that we value assessing our own practice and ensuring that what we do, we don't just assume that we provide good care or equitable care, but we actually can demonstrate that we do that.
I think Dr. Fancher's point is well taken. We have the chairman of the Department of Psychiatry and Behavioral Science here at Howard, Dr. William Lawson, has done quite a bit of work just looking at misdiagnosis among patients presenting with psychiatric symptoms that are black as compared to white, that the number of persons who have bipolar disorder who are misdiagnosed as schizophrenia because of biases, I would say, and failure to use evidence-based methods in coming to the diagnosis. So it's not just bringing in a more diverse workforce, which is important, but looking at the records to confirm that we are delivering appropriate care to the appropriate diagnosis.
Very, very good. One of the things at our institution that we're doing, University of Chicago, is run by Dr. Marshall Chen, in which they're trying to investigate solutions to solve health disparities problems. And it's been funded by the Robert Wood Johnson, and they provide small pilot grants to individuals, faculties, and communities to try to work together, to try to figure out ways in which you can interface more in the community, to try to figure out what community-based needs are. We've also engaged under the leadership of Dr. Dorian Miller, a way of trying to understand what assets exist on the south side of Chicago. So there's the asset mapping project that's gone on, health asset mapping project, as part of the Chicago Health and Vitality Studies. I mean, those sorts of things to see where things are in the community and what needs are specifically, I think allows an organization or an institution such as the University of Chicago, which is one of the largest institutions on the south side of Chicago, to really look at what needs to be done in the South Side minority communities in order to try to help improve healthcare in general. Let's see.
Could I ask a question to Julia? Julia, at your school, do you do some of the work that Dr. Bland talked about as far as unconscious bias? I know we do some of that with the students, talking about unconscious bias or about unequal treatment, and have them actually complete the Harvard online survey of unconscious bias. Have you done that as a student?
I have not done that as a student. Not at. I did that in public health school. I actually didn't do it here in medical school. I am familiar with that, but we do take a course called Culture and Healthcare, and it's required for all first-year students, not just medical students. So literally every first-year student throughout the university takes this class, and it's where we discuss a lot of different topics surrounding culture, what culture means, what our own culture means, coming up with our own, not defining, or I guess framing our own self-identity, and kind of then using case studies to be able to discuss, how we would handle a different situation, not only as a medical student, but maybe as a podiatrist or as a medical physicist, or depending on which program you're in. So we have that course, and that's a full year throughout our first year of medical school. So we do it in a different way, but we do have something that's similar, yeah.
Thanks very much.
I have a question for Jalea.
Oh, please, go ahead.
Okay. Do you think that course helps in terms of interprofessional communication and being able to deliver system-based care to patients?
I think it does. I mean, I will be honest, before partaking in that course, I had no idea what a lot of the other professions did. I didn't really know how, in a professional sense, I would even engage with them. So it definitely provided the opportunity to be able to learn from other people in other programs about how we may work together in the future, and then how we can kind of work together on the same, or even think differently about the same patient case, but how we really do need each other in order to give the best medicine and kind of have the best outcomes as well. So I think definitely it sets people up to be able to think differently and kind of think more collectively in a team-based approach. I will say I think it's unfortunate we only have it for that 1 year. I do think it's one of those courses that needs a continuum. But it definitely lays a pretty good framework and foundation for moving forward.
Because I'm thinking about my medical education. We only had one course that was interprofessional in nature, and in most circumstances it was assumed that the physician was in charge, even though the physician might not have been the best person to carry out the task.
Interprofessionalism at my school that's one of our largest pillars. We in the medical school we take courses with podiatrists, we take courses with the pathicists, we take courses with almost everyone. So the idea of interprofessionalism is really built really well into the curriculum, in that a large majority of our courses are with other health professions. So we get to learn, a little bit more than we might need to, because there is another specialty that's in the class with us. So it's kind of getting an idea of what it is that they know and what their scope of practice is, in order to be able to better help us learn how to work together. So I think it works pretty well. I mean, I enjoy it. So.
Wow. Well, thank you very much for that input. Our next question will deal with how your institution teaches racial and ethnic health disparities and the role of population health in clinical medicine. And is there anything that is being done that's innovative in that regard? I will tell you, at the University of Chicago, one of my colleagues, Dr. Monica Vela, developed a course on, and that's the very first course that a Pritzker student takes here at the University of Chicago, on health disparities in America. And we found that by getting students involved in that course, not only does it help them understand more about health disparities and what their role will be, by putting it as the first course, it really sets the tone for all the other things that happen in the medical curriculum that deal with health disparities, and it helps people find a place to involve themselves in what's going on with health disparity elimination on our campus. And we've actually found that it helps to improve underrepresented minority medical student recruitment, because we have that course, and because medical student applicants see that as an asset and something that they want to become a part of. Is there anything in that regard in teaching health disparities or population clinical medicine that actually is effective for you in your institution? We'll go to Dr. Fancher.
We do have health disparities throughout the curriculum, but I guess the piece that I would highlight is in the summer between the first and second year, we offer a course that's called the Summer Institute on Race and Health, and it really looks back at history and the way history has led to differences in populations, and even talks about whether or not race is actually a construct. So that sort of the tagline is race is a social construct, right? And really to getting the students to understand what the historical experiences have been of people that have then led to perhaps mistrust of the system, or challenges with access to care, or poverty, or we really try to focus on Sacramento and our local community, since that's the group that we're serving right now. So the students do quite a bit around redlining and understanding how redlining and housing discrimination has led to has really created a ceiling for many of our local communities, and this inability to sort of to overcome, right? That's because of structure. It's not an intrinsic innate value, right? It's a structure that's been placed on communities.
That's very interesting. Dr. Bland, I know Howard is very active in this. Is there anything particular that you want to tell us about?
Well, we incorporate information about health care and health disparities throughout our courses in the discussions and clinical rounds, case conferences, our grand rounds, as well as in our didactic lectures. We look at how effective we're doing this through internal surveys as well as through the graduation questionnaire that our senior students fill out during, well, they're supposed to start midway through the senior year, but many of them finish until April at our senior students. So we do not have a course per se, but it's integral to the curriculum, and it occurs throughout the 4 years of matriculation.
I would expect that you probably should have 100% of your seniors that say they've been taught something about health disparities, but I kind of imagine that's not true.
That's not true, unfortunately, but it's pretty close to that.
Very good. Jalila, what do you do at Rosalind Franklin that's part of the curriculum to teach you more about health disparities?
So as I spoke of before, we have our culture in healthcare class, but also there's a variety of research opportunities that students have between the first and second year. My school has a partnership with Sinai Urban Health Institute, so they accept 10 students every summer between their first and second year, and they're able to do a variety of health disparity research. And then we also have a variety of study abroad programs. This past summer, I was actually able to go to Bolivia, and it's called Culture and Healthcare in Other Countries, so like essentially third world countries. And I mean, that was a great experience, supported by my school, that I was able to go and spend 4 weeks in Bolivia and kind of learn about their healthcare system, shadow in a variety of different specialties, and just learn about healthcare and practice in a third world country. So those are some of the things that we do.
I imagine those research internships that you've talked about, research experiences, allow you to develop mentors who help them to guide your career in thinking about health disparities as a career, or elimination of health disparities as a career. Are there other sort of mentorship programs that you have at your institution that are specifically focused on diverse students and trying to help those diverse students understand the nature and the extent of the problem so they really see their value in the healthcare setting? We'll go to Dr. Fancher.
Yeah, we have a very structured mentorship program that really takes advantage of the diverse faculty as well as the diverse resident population here, and then for non-physician participants as well. So really with nursing school, et cetera. And that as our student population is grows and the interests grow, those continue to grow every year as well. So we're lucky to have an Office of Student and Resident Diversity that's incredibly active and incredibly supportive of the students. The students, you know, they bring to us all of their knowledge and passion, right? And so a lot of that goes through the Office of Diversity, who then helps them to connect with others who will help them to fulfill their dream. So, for example, a couple of the students now are working on a new student-run clinic to really be responsive to their community. Others are looking at the issue of, and I know this is true in Chicago as well, and probably at Dr. Bland, but for students who come through and are DREAM Act students, right, who are incredibly talented, committed students, and then how can we as a community help them to fund medical? So that's, you know, another, I guess, example of really student-driven passion that then that the Office of Diversity has helped them to find the right people to help them find an answer.
Dr. Bland, what do we do in terms of mentorship at Howard? How do we help to try to direct more of our underrepresented minority students into health disparities work or into the academy as academic medical educators?
Well, at Howard, we start mentoring and career advancement in the first year, which I'm sure that most medical schools now do. In the first year, students are assigned a clinical as well as a basic science advisor to serve as mentor. They have opportunities to shadow the clinical advisor, but also to work closely with the basic science advisor in terms of research that they can become involved with, which is important for persons who are considering academic careers. During the summer between our students' first and second year, many engage in student research at Howard as well as other institutions. You may be familiar with the Intervention program, where they take underrepresented minority students who are interested in orthopedics and pair them with orthopedic researchers throughout the country. And we've been able to have a number of our students selected for that program. They have presented at the Orthopedic Society meeting as well as the NMA meeting and Student Medical Education meeting. So we start the mentoring early. We have that formal mentoring system, and then we have the informal. Students can approach any faculty member to talk about their interests, and someone is willing to listen to them. So we encourage both.
Very good, very good. At the University of Chicago several years ago, we started the society that's named after Dr. James E. Bowman, a pioneer in sickle cell disease research and the first African-American tenured faculty in the Biological Sciences Division here. And the reason we started it was we didn't want to lose any of our junior faculty to lack of tenure or lack of advancement in the faculty ranks. And what we realized that we have a lot of medical students and residents who come to the University of Chicago because they think they want to start careers in academic medicine. So we've now included residents and medical students in the Bowman Society, which has both a lectureship that brings people into fellowship as well as a community meeting of minority folks who are interested in academic medicine careers. And I hope that by establishing both formal and informal mentorship through the Bowman Society, we're able to keep people in academic medicine so they can be in a place where they can actually study health disparities with an eye toward elimination. Well, we're nearing the end of our chat. We've got about 2 minutes left. I would like to invite the panelists to make any closing remarks they have about health disparities or how medical education can help to eliminate health disparities. And I'll start with Jalea.
So I think what's been key for me in my medical school especially is their willingness to kind of take student feedback about what our interests are in terms of creating a more diverse curriculum for teaching us different things about health disparities and about a variety of different communities, and their willingness to take our feedback and actually within 1 to 2 years actually input it into the medical curriculum. So for me, that's been, I mean, since in my 2 years in medical school, the drastic change that I've witnessed and also experienced in terms of electives that have been added and other courses that have been significantly changed to incorporate other what we consider value-added groups into my medical education has definitely been the most beneficial.
Well, you have a wonderful dean there, Dr. Olivier, and, and I hope she keeps supporting you the way she has been. Dr. Fancher, do you have any closing comments for us?
I think the only thing I would say is, to me, it's all about the students. So it's creating the environment for we know who the students are. We know that they have the passion and the talent to do this job. So our job as educators is to create the environment that ensures their success.
I think that is key. That is very much key. And Dr. Bland, do you have any closing comments for us?
The only comment that I have is that in addition to talking about and having conferences on health disparities, we need to make sure that we fund programs that provide services. to persons who are being subjected to these disparities. I think that not enough emphasis is placed on service delivery.
I think you're very much right on that one. I think the value of diversity is really the key thing here. That diversity is really excellence. And you can't have excellence unless you have diversity. And I think medical schools have really figured this out now to some degree. Some schools are kind of lagging behind in terms of doing the innovative things that it takes to develop that medical school class. And it's our great hope that through the AMA's work and through the work that you're doing in your institutions, that medical schools can really see how important it is to have diverse classes into the future and to ensure that their selection process for candidates, as Dr. Bland says, takes a holistic approach. So I'd like to thank everyone for their time and their energy and the work that you do on a daily basis to help educate our medical students, our residents, and work with our faculty to study ways to end and reduce healthcare disparities as we know them today. I'd like to thank the American Medical Association for providing the opportunity for us to hold this Google chat, and elements of this chat will be available online afterwards. And I'd like to thank you all for your time and evening tonight, and I wish you all well. Good night.